Hello, my name is Ritchie, and I would like to welcome you to Bridging Gaps in Unhoused Healthcare. Unhoused individuals experience significant health disparities stemming from limited access to care, structural inequalities, and unmet social determinants of health. This presentation summarizes evidence-based strategies that support engagement in healthcare settings and explores secondary data from a student-led clinic serving unhoused adults to highlight multidisciplinary approaches that improve continuity of care, trust, and health outcomes for the unhoused. I would like to now introduce Cheryl Chambers.
Thank you, Arnise. Hello, my name is Cheryl Chambers, and today I'm sharing the methodology and the results from the existing research. This research took place in a student-run clinic located within a homeless drop-in center in Houston. What I appreciated about this setting is that it's not a traditional hospital or office. It's embedded directly in the community, which makes care accessible and less intimidating. The team reviewed records from about 191 patients and looked at things like demographics, social determinants of health, diagnosis, and what actions providers took during their visit. So, really, what they were asking was simple but important questions. Who is coming? What are they experiencing? And how are we responding to their needs? Nearly half of the patients either declined care or left before treatment even started. To me, that says this isn't just a medical issue, it's about trust, stability, and competing with survival priorities. Housing insecurity showed up the most, which isn't surprising, but what stood out was how many people were juggling multiple stressors. Younger adults between 18 and 29 had the highest rate of substance use concerns, which really points to the need for early behavioral health support and prevention. The study also reveals some disparities that are important to sit with. Black and Hispanic patients were more likely to receive diagnoses labeled as normal or unremarkable, while white patients more often received pain-related or musculoskeletal diagnoses. And gender differences showed up too. Men were more likely to receive medications, while women were more often referred elsewhere for care. These patterns don't necessarily tell us intent, but they do raise important questions about bias, perception, and how we make clinical decisions. For me, this really reinforces why trauma informed and culturally responsive care isn't optional, it's essential if we want equity in our outcomes. The next slide explains why these findings matter. And I would like to introduce Tamika Culver to close out this presentation.
Thank you, Cheryl. My name is Tamika Culver. Results demonstrate persistent barriers and inequities in unhoused healthcare and highlight student-run clinics as essential trauma-informed access points. To wrap up, the evidence shows that engaging unhoused individuals work best when care is flexible, trauma-informed, and built on trust. Programs like student-run clinics, mobile outreach, and medical respite improve access and help stabilize care. To make these efforts sustainable, practitioners and leaders must address social detriments of health, reduce structural barriers, and use culturally responsive approaches. Expanding low barrier community based services is essential to building more equitable systems of care. Thank you so much for sharing this moment with us as we discuss how to support the needs of unhoused individuals.